Hi guys, welcome to Podcast Med. The topic of discussion in this podcast is diagnosis of pregnancy. Basically, diagnosis of pregnancy will be discussing under the following headings. Okay, trimester-wise changes and what can we do to diagnose pregnancy in that particular trimester, and then few miscellaneous topics regarding USG, fetal weight estimation, signs of previous childbirth, gestational age, and prediction of expected delivery date, etc. And all the other differential diagnoses of pregnancy. Now, coming to the first trimester complaints, this trimester wise complaints and changes, we already saw it in the physiological changes in pregnancy. Okay, now in this diagnosis of pregnancy, we'll see it briefly here and then leave it. Okay, coming to the first trimester complaints, firstly, anyone can notice that is amenorrhea. What is amenorrhea? That is absence of a menstrual period. Okay. However, cyclical bleeding can occur at 12 weeks of pregnancy until the decidual space is obliterated by fusion of decidua vera with decidua capsularis. So this is called implantation bleeding. Okay. This is termed as placental sign. Okay, this is also called placental sign. Now, coming to the other things that we observe during the first trimester are morning sickness. Morning sickness is what? Nausea and vomiting during the pregnancy. It usually appears following the missed period, and rarely it goes beyond 16 weeks. Okay, it will last till only 16 weeks. Mostly till 16 weeks, and it is present in about 70% of the cases. Not all the cases have it, but mostly 70% of the cases have it. And we'll have frequency of micturition. Sorry for the sound. And we'll have frequency of micturition. Frequency of micturition, what? Urinary frequency increases. Why is this? Because of three reasons. Okay, mainly three reasons. First is it is due to uterus pressurizing the bulky uterus pressurizing the urinary bladder. Okay, bulky uterus on the fundus of the bladder will exert pressure. Okay, because of anteverted position of uterus. And then the second reason is congestion of the bladder mucosa. Then third reason is change in maternal osmoregulation. All of these things we have already discussed in the physiological changes in pregnancy. If you are not able to understand it here, you can go back to the physiological changes in pregnancy podcast and then refer to it. Now we'll also have breast discomfort. Okay, it's a form of feeling of fullness and pricking sensation will be there. Then we can also experience fatigue. Okay, the patient can also experience fatigue, not we. And then coming to the objective signs, all of these are subjective signs where the patient feels herself. Okay, objective signs is what we observe. Okay, breast changes. Firstly, breast changes in primigravida it is very prominent and valuable, because in multiparas breasts are already enlarged and often contain milk for years. Okay, so that is not the complete evidence of pregnancy. Then we'll have this. Normally we have talked about nipple, areola, Montgomery tubercle formation and all, and secondary areola formation. All of this will happen. Parabdominally, what happens? Uterus normally is a pelvic organ. Okay, until 12th week. Then after that, 12th week, it might become a abdominal organ because of increase in fundal height or uterine size because of growing fetus. Until 12th week, it is just felt as a suprapubic bulge per abdomen. When you do parabdominal examination, it is felt as a suprapubic bulge. Then coming to the pelvic changes that we observe, these are objective changes that we observe. Okay, signs, symptoms and signs kind of. Okay, coming to the pelvic changes, we have a few of the signs here. What are the Jacquemer or Chadwick sign? What is that? That is a bluish discoloration of vestibule and anterior vaginal wall. It is visible at about 8th week of pregnancy. Then coming to vaginal signs. Vaginal signs, we have Osiander sign. What is Osiander sign? It is increased pulsation felt through lateral pornesis at eighth week. That is at eighth week of pregnancy. Again, this is also at eighth week of pregnancy. What are lateral pornesis? Pornesis are what? That junction of vagina and cervix पे एक smiley symbol के तरह होती है. Those are called fornices. Okay. We also have other changes in vagina, like bluish discoloration of anterior vaginal wall. What is that again called? Jacquemer sign. Okay. And then there is non-irritating mucus discharge also is present till at 6th week. Copious non-irritating mucus discharge is present. Then coming to the cervical signs, we have Jacquemer sign, Osiander sign completed. Then coming to cervical sign, we have Goodell sign here. Okay, Goodell sign is what? Cervix becomes soft as early as 6th week. Till 6th week, the cervix becomes soft. 8th week till 8th week, Jacquemer sign, Osiander sign we can observe. Till 6th week, we can observe Goodell sign. Okay, these are the cervical signs. And on speculum examination, the bluish discoloration of the cervix is visible. It is due to increased vascularity. Basically, there is so much of blood supply. There is so much of vascularity towards the uterus as the fetus grows. Okay, because of this increased vascularity, there might be congestion. There might be bluish discoloration kind of things that happens in the female reproductive organs. Then coming to the uterine signs. In uterine signs, normally all the uterine changes we have already discussed in physiology. Particularly, if we have to talk here, we will talk about the Pisca-Sex sign. Okay, what is Pisca-Sex sign? The spelling is Piscaceeks. Okay, Pisca-Sex. This is what? There may be asymmetrical enlargement of uterus in some cases if there is lateral implantation. Okay, that is Pisca-Sex sign, where one half is more than the other half of the uterus. That bulged abdomen will be there, in that the one lateral half is more bulged than the other because of the lateral implantation. Fundus, normally it will get centrally implanted, but in few cases if it is laterally implanted, there will be lateral more bulging in the lateral side. That is Pisca-Sex sign. Then coming to the Hagar sign. Hagar sign is what? It is almost present in 2/3 of the cases. Okay, it can be demonstrated between 6 and 10 weeks, and a little earlier in multiparous moment. Okay, this sign is based on the fact that upper part of the body of uterus is enlarged by growing fetus. Okay, lower part of the body is empty and extremely soft. The cervix is comparatively firm. Okay, because of the variation in consistency on bimanual examination, 2 fingers in the anterior fornix, where we keep 2 fingers in the anterior fornix and 2 fingers in the two abdominal fingers behind the uterus. Okay, 2 vaginal fingers and 2 abdominal fingers. Basically, the abdominal and vaginal fingers will seem to oppose below the body of uterus because of these 3 reasons. Then coming to the Palmar sign. What is Palmar sign? Regular and rhythmic uterine contractions that are elicited during bimanual examination as early as 4 to 8 weeks. So till now, how many signs we have discussed? Jacquemer sign or Chadwick sign, then Osiander sign, Goodell sign, Pisca-Sex sign, Hagar sign, Palmar sign. These are the 6 signs that we have discussed. Then coming to the immunological tests that we can do is based on just HCG levels. HCG levels raised during the pregnancy, but we should be careful in differentiating HCG levels in pregnancy due to ectopic pregnancy and normal pregnancy. Okay, and we can detect that HCG levels by urinary pregnancy test kit, but it is not completely correct always. There might be variations, but gold standard one for this is ELISA. What is that? Enzyme linked immunosorbent assay, as we all have studied it in microbiology. Then coming to other uses of pregnancy tests, that we do, other uses of this tests are to monitor the pregnancy following in vitro fertilization, IVF and embryo transfer. After that, we can monitor it by these tests. Then we can follow up the cases for hydatidiform mole and choriocarcinoma. Okay, not only enzyme linked ELISA for HCG, we can also do transvaginal ultrasonography. Okay, there we can see gestational sac, yolk sac, presence of yolk sac, gestational sac, fetal pole, and in the first trimester we only see gestational sac and this what is that yolk sac. Sometimes we can also see crown rump length if possible. These are the three things that we can see in the first trimester. But later in the next trimester, we can even see what is the femur length, head circumference, abdominal circumference, etc. All of these also we can see through USG, that is transvaginal ultrasonography. Okay, TVS, it is called transvaginal ultrasonography, TVS. Then cases with positive pregnancy tests without actual pregnancy. These are the conditions where there is positive pregnancy test results but without actual pregnancy. Those can be women having exogenous HCG injection. If she has taken HCG injection, then it can also be due to delayed HCG clearance due to renal failure. In case of renal failures, then also it can be due to presence of pituitary HCG. Physiological, it is normal physiological, but we have to be careful about how much the quantity of HCG that is present. Okay, then it can be due to neoplasms producing HCG like ovary, ovarian, lung, bladder or gastrointestinal tract, wherever it can be. Then coming to the second trimester, as we all know, second trimester subjective symptoms are quickening and progressive enlargement of the abdomen. What is quickening? Quickening is actually feeling of life inside. Okay, this denotes a perception of active fetal movements by the woman. It is normally around 18th week. It is felt in the primi gravida, and about 2 weeks later, like by 2 weeks earlier, like by 16th week, multipara can feel quickening. Okay. Then after this quickening can also be useful in calculating gestational age approximately. Okay. Then on general examination during second trimester, we can see chloasma, which is pigmentation over the forehead and cheek that we already discussed. Then we can see all the other breast changes that we have discussed about. Colostrum becomes thick and yellowish by 16th week. Okay, all of these things happen. Then coming to the abdominal examination, that is general examination. This is abdominal examination. In abdominal examination, we see linea nigra, stria gravidum, all of these things, that marks on the abdomen will be seen. Then on palpation, obviously those fundal grips will be doing, those four, not fundal grips, those obstetric grips, those 4 obstetric grips will be doing and approximately seeing what is happening over there. Then the uterus also, on palpation, the uterus feels actually soft and elastic and it becomes ovoid in shape. We also can okay, this is little controversial here. In the previous chapters like physiological changes in pregnancy, Datta has mentioned Braxton Hicks contractions are not actually sensed by the woman, but here he is mentioning Braxton Hicks contraction are actually felt by her. I don't know what to actually remember, but I'll see and say. Okay, fetal parts are palpated. Okay, distinctly, it can be very nicely palpated, fetal parts, and then active fetal movements can be detected. It gives positive evidence of pregnancy and live fetus. Okay, and also we can see for external bellatment. We'll see further in the next podcast about bellatment, what is bellatment and all. And on auscultation, we can hear fetal heart sound. It is the most conclusive clinical sign of pregnancy. Okay, 2 other sounds that we actually get confused with fetal heart sounds are uterine souffle and phonic or fetal souffle. What is uterine shuffle? It is a soft blowing and systolic murmur heard low down by sides of uterus. Okay, the sound is synchronous actually with maternal pulse and is due to increase in blood flow through dilated uterine well. This is basically uterine artery pulsations that we hear here. Okay, then coming to the phonic or fetal shuffle, it is due to rush of blood through the umbilical arteries, that is uterine artery, and this is umbilical arteries. It is soft blowing murmur synchronous with fetal heart sounds. Uterine shuffle is synchronous with maternal heart beats. Okay, this is synchronous with fetal heart sounds, so it is called fetal shuffle. That is uterine shuffle. Then coming to the vaginal examination, this is not commonly done in the second trimester because there are chances of damaging or mucus plug. Don't know, like few. It is risky thing that to be doing it in the second trimester. Then coming to the ultrasonography, as I've already said, under ultrasonography we'll be examining head circumference, abdominal circumference, femur length, and all the other things that we have discussed, like gestational or yolk sac, crown rump length, all of those. And we can also do MRI, fetal organ anatomy. All of these can be done in the second trimester. And coming to the last trimester may we'll see amenorrhea, actually same those things, and there is further enlargement and there is lightening at about, what is lightening? At about 38th week, especially in primees, a sense of relief of pressure symptoms. A sense of relief of pressure symptoms is obtained. It is due to engagement of the presenting part. What is that? Abdomen to pelvic. The head will go and get engaged in the pelvis. So this is engagement. Because of this, there is relief of pressure symptoms in mother. So this is called lightening, and there is again increased frequency of micturition, and there are more pronounced fetal movements. Coming to the signs, same cutaneous signs, same uterine shape, fundal height. Based on the grips or something like that, while palpation, we have to calculate fundal height and try to compare it with the gestational age. Try to compare it by gestational age. Okay. Then we can see Braxton Hicks contraction, fetal movement, palpation of fetal parts, all of this that we have already discussed. FHS, what is that? Fetal heart sound may not be audible in cases of maternal obesity. If the mother is very obese and there is polyhydramnios or occipito-posterior position, and in case of IUFD, intrauterine fetal distress, in all of these cases there can be absence of fetal heart sound. Then coming to differential diagnosis of pregnancy, what can the other things be? Pseudocyesis. This is the most famous thing that we have already heard in forensic medicine toxicology, which is pseudocyesis. What is pseudocyesis? It is phantom pregnancy or spurious pregnancy or false pregnancy, where it is a psychological disorder where the woman has the false but firm belief that she is pregnant, although no pregnancy actually exists. The woman often is infertile who has an intense desire to have a baby. So the conspicuous feature is cessation of menstruation. Here it is very very like the power of mind. I don't know why she keeps thinking she's pregnant and she actually loses her period. There is no period, no menstruation in this, and on obstetric examination there it will be proved that there is no pregnancy, but all the few other symptoms that we see in pregnancy will be there. There will even be false labor pains also, like at that moment. And there is enlargement of abdomen also. See how fascinating is that. And the other diagnosis are cystic ovarian tumors, fibroids, full urinary bladder. All of this can be the other DDs, differential diagnosis of pregnancy. Then coming to use of USG parameters for fetal assessment. After 20 weeks, we can do fetal growth profile, okay, based on biparietal diameter, head circumference, abdominal circumference, and femur length. And estimated fetal weight is determined by the following parameters, the above ones only. Then we can also determine liquor volume, placentation. We can see if placentation, fetal anatomical survey also can be done. There is this small thing called signs of previous childbirth, like breast become flabby, nipples are prominent, abdominal wall is more lax and loose, uterine wall is less rigid, perineum is lax. There might be episiotomy scar or something like that. Introitus is gaping, and vagina is more roomy. All of these things can be signs of previous childbirth as well. And then we have estimation of gestational age and prediction of expected delivery date. We know till now that there is Naegeli's formula that is useful for calculation of expected delivery date. Gestational age will normally see by fundal height or something like that. Fundal height also, like we can compare it. No, it's not at all reliable, but because there may be things where the fundal height is less than the gestational age and fundal height is more than the expected gestational age ka fundal height. Okay, coming to the things that help in calculation of gestational age and EDD is date of fruitful coitus. Exactly, if she or he remembers what is the date of fruitful coitus exactly, then there are higher chances of predicting the correct range, like 50% with 7 days on either side. Like either side will 7 days if you add and subtract, that gives the EDD. If that EDD which came out of this can vary 7 days right and left. Okay, then coming to Naegeli's formula we all know. We have to see for last menstrual period plus 9 months plus 7 days. This is normal formula. And if there are any irregular cycles, if the days of cycle are less than 28 days, then you should add those days which are less. Okay, and if they are more than 28 days, we should subtract the days that are actually more. Extra difference you should add and subtract in case of irregular periods. Then we can also predict EDD and gestational age by date of quickening. It will give a rough idea only, but this also can be useful. And there is estimation of fetal weight. Now coming to the estimation of fetal weight, we can do it by two methods basically: fetal growth velocity method and sonography. Fetal growth velocity, there is what happens, conditional centiles depending on individual fetal growth velocity is thought to be more important. I don't know, I just read the line given here, but just remember it like that. And coming to the sonography, from sonography, after getting BPD, HC, AC and FL, that is biparietal diameter, head circumference, abdominal circumference and femur length. After getting all of this, we can use two formulas to get this, which are Hadlock's formula, Harlock's formula and Shepard's formula. Okay, Harlock's formula is okay, wait, this is a little complex though. AC, okay, log 10 weight is equal to 1.326 minus 0.00326 into AC into FL plus 0.0107 into HC plus 0.438 into AC plus 0.158 into FL. Wow, this is such a complex formula it is. Then coming to the Shepard's formula, we have log 10 EFW, that is estimated fetal weight, is equal to 1.2508 plus bracket में 0.166 into biparietal diameter plus 0.046 into AC minus in the bracket 0.002646 into AC into BPD bracket close. those are such complex formulas. I didn't read it while reading the textbook. I just underlined that. No, now this completes the diagnosis of pregnancy.